Heidi Ehrenreich. I'm the project director for Hope for Georgia Moms. And it gives me great pleasure to introduce Dr. Jane Ellis today. I got to say, her reputation sort of preceded her when I got to know her over time. And the reason is she wears so many hats. She's just so very active. I knew she was on the Quality Collaborative GAP QC's advisory board. She's on the Maternal Mortality Review Committee, the MMRC, which we'll present on today. She was working with the Regional Perinatal Center. She's the medical director. So she really was somebody who was a great force. And I was so excited that we got to work together side by side in a retreat just in August. And we talked about our strategic planning for the Hope for Georgia program, and she's also on the task force with us. So let me read a little bit about her background. Dr. Jane Ellis is the Associate Professor in the Division of Maternal-Fetal Medicine, Department of Gynecology and Obstetrics at Emory University of Medicine. She is a Georgia native and grew up in the Brunswick-St. Simons area. She attended Georgia Tech, and she received her BS, MS, and PhD there. And then she attended medical school at Emory University, where she pursued also her residency training in obstetrics and gynecology. And then following this completion of her residency, she pursued a fellowship in maternal-fetal medicine at Emory. She joined the faculty of Emory in 2005 and has been an attending physician at the obstetrics service at Grady Memorial Hospital. She is actively involved in medical student resident and fellow training and teaching at Grady and has won several teaching and research awards. And she is the medical director for the Emory Regional Perinatal Center at the Grady Health System, which is the largest regional perinatal center in the state. And it's responsible for the quality of obstetric care provided in the 40-county North Georgia regional area. And that includes our county as well. And we work together with that Regional Perinatal Center, where she is the medical director of. Dr. Ellis is the OB medical director for the M&I grant, which is a grant funded by both federal and state monies to ensure quality care for indigent pregnant women at Grady and other regional perinatal centers. And she is the founding and current member of Georgia's Maternal Mortality Review Committee, MMRC, and is actively involved in the implementation of local, regional, and state patient safety and quality initiatives, such as the AIM Patient Safety Bundles. She works with the Georgia Perinatal Quality Collaborative, GAP QC, and Levels of Care Initiative, which is going through the House Bill 909. She's also active at the national level in the American College of Obstetrics and Gynecologists Committee on Maternal Mortality. And Dr. Ellis has particular interest in identifying causes of and reducing maternal mortality, patient safety, and quality initiatives, and maternal-fetal outcomes in pregnant patients with medical comorbidities. So as you can see, she has a very fantastic resume, and we're very excited that you're able to come in virtually presenting today. There's just a couple approval statements we have for CME and CE credit. And I would like to just treat Northeast Georgia Health System as approved as a provider of the nursing continuing professional development by the Northeast Georgia Multi-State Division Education Unit, and an accredited approver of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. And then the next slide, please, is that she has no individuals in a position to control content for this activity or have any relevant financial relationships to declare. And there's no commercial support for her being here and for this event. And then for successful completion of this learning event, you must complete a short CE or CME activity credit, and there's no partial credit available. And you'll receive a SurveyMonkey link after today's activity to complete that accreditation credit process. So please welcome, or join me in welcoming Dr. Ellis.
Thank you. I apologize. I had planned to be there in person, but my plans changed this morning. I had to stay in Atlanta. So here we are on good old Zoom. I can't remember the days now where we didn't have Zoom available. And I guess it saves us in a lot of situations. So I really appreciate that introduction, Heidi. And I've enjoyed working with Heidi and Bridget and Mary Lou on cardiac initiatives for obstetric patients that will be rolling out through Northeast Georgia. So again, I'm very happy to speak with you this afternoon about maternal mortality in Georgia. Next slide, please. And let me just say, my dogs, I'm at home, so my dog, I have two Border Collies and an Australian Shepherd, who cannot figure out why I'm at home at this time of day. They're in and out with balls and frisbees. I'm trying to make sure everybody stays quiet, but there may be some barking in just a minute. So I have no disclosures to make. And I just wanted to say that today I'm not speaking as a member of the Maternal Mortality Review Committee or for Grady or for Emory or for DPH or Department of Public Health. But I'm really speaking as a provider who has the privilege of taking care of a lot of high risk and complicated pregnant patients. And I'm glad to see that we are all on the same page, moving in the direction of providing care that will improve the outcomes of all our pregnant patients and their families in Georgia and across the state, because I believe that they deserve our best efforts. So in talking about maternal mortality, we're going to look at some basic objectives today. We'll look at terminology that's important to understand. We'll talk about the current status of maternal deaths worldwide and in the US, just briefly, just for perspective, and then we'll focus on what's happening here in Georgia. We'll highlight Georgia's leading causes of pregnancy-related and pregnancy-associated deaths, and then we'll look at recommendations made for reducing maternal deaths from the Maternal Mortality Review Committee. Next, okay, and our Maternal Mortality Review Committee, as do most state committees, follow definitions that have been outlined by the CDC. So a maternal mortality, I think there's one slide back. Can you go back one? Okay, so a pregnancy-associated maternal death. This is the death of a woman while pregnant or within 1 year of the end of her pregnancy due to a cause that's unrelated to the pregnancy. For example, if she's pregnant and she's killed in a motor vehicle accident, she dies in a drive-by shooting and a house fire, those are considered pregnancy-associated deaths. She did not die due to a cause related to the pregnancy. Pregnancy-related deaths, on the other hand, are the death of a woman while pregnant or within 1 year of the end of the pregnancy due to any cause related to or aggravated by the pregnancy or its management. So this would include a patient who died from a postpartum hemorrhage, from an eclamptic seizure, who has a uterine rupture, a placental abruption, amniotic fluid embolus, something that comes directly from the pregnancy itself. The phrasing 1 year within the pregnancy of the end of the pregnancy is included because when many states set up their maternal mortality review committees, they just looked at the first 6 weeks after the end of a pregnancy. Georgia was actually one of the first states to say, no, let's look out an entire year. And by doing that, we found a lot of pregnancy-associated deaths, particularly those due to substance abuse and mental health conditions. So now I think all of the states that have the Maternal Mortality Review Committee set up, which is now most states, do look a full year out. But in general, when you're talking about or hear people talking about maternal deaths, typically they're including both pregnancy-associated and pregnancy-related deaths. Next, please. A Maternal Mortality Review Committee. This is usually a multidisciplinary committee that's set up at a state level to review maternal deaths, determine the causes of deaths, determine if the deaths were pregnancy-related or associated, determine preventability, and then make recommendations to reduce maternal mortality. You'll hear the statistic maternal mortality ratio discussed a lot. This is the number of pregnancy-related deaths per 100,000 live births, usually over a 1 year period. And then preventability. Per CDC, a death is considered preventable if the review committee determines that there was at least some chance of the death being averted by one or more reasonable changes to patient, community, provider, family, and or system factors. And believe me, we spend a lot of time in the committee meetings trying to determine the preventability of a death and making sure we have it, we designate whether it's preventable or not accurately. So let's talk about maternal mortality worldwide just quickly. On average, a woman dies, go back, on average, thank you. On average, one more back. Okay, so a woman dies of a pregnancy-related cause somewhere in the world every 2 minutes. Most of these deaths are considered to would be preventable if the patient had the right access to care at the right time. Next. On average, this means that 770 women die each day from preventable causes related to pregnancy and childbirth. So in the year 2020, for example, 287,000 women died during and following childbirth. The maternal mortality ratio in the high-income countries, such as the US, on average is 12 per 100,000 live births versus 430 maternal death, pregnancy-related deaths per 100,000 live births in low-income countries. And these are statistics from 2020. Last year, I think in 2021, South Sudan, I believe, recorded the highest maternal mortality ratio ever noted. They had 1,722 maternal deaths for every 100,000 live births. More than 90% of maternal deaths occur in developing and low resource settings. Next. And I think if you go back one more. Forward one more. Okay, thank you. The leading causes of death worldwide are hemorrhage, infection, complication from delivery, and unsafe abortion. And of course, most of these deaths would be preventable if these patients had access to adequate prenatal care, skilled care during delivery, and good postpartum care following their delivery. But of course, these are typically things not available in low resource settings. Next. So let's look at what's happening in maternal mortality here in the US. And I think we can do 4 facts and 4 graphs. We'll look at the US ranking, Black-white disparities, leading causes of maternal deaths, and then look at trends in maternal mortality in the US between 2018 and 2021. Next. Okay, maternal mortality worldwide has been dropping since 1990, except in the US. The maternal mortality ratio has been rising steadily in the US over the past few years. And as you can see in this graph, in 2020, the US maternal mortality ratio was 23.8. The next highest developed country was France with a maternal mortality ratio of 8.7. Proposed reasons for the higher rates in the US, despite our good healthcare system, are our high C-section rate, inadequate prenatal care, elevated rates of chronic illnesses such as diabetes, hypertension, and obesity, missed or delayed opportunities for treatment. Next. Black women face 3 times the maternal mortality risk as white women. So in 2020, the maternal mortality ratio for Black mothers in the US was 55 versus 19 for white mothers and 18 for Hispanic mothers. The reasons for this are not clear, but the proposed reasons include underlying chronic conditions such as diabetes and high blood pressure, variation in the quality of health care, social determinants of health, structural racism, and implicit bias. Next. The leading causes of maternal mortality in the US are cardiovascular conditions, infection of sepsis, hemorrhage, thromboembolic events, and hypertensive disorders of pregnancy. And if you look at this bar graph, CDC breaks down a lot of the causes of death into different categories. So if you look at the bar on the far left and then the third from the left, these are other cardiovascular conditions and cardiomyopathy. When those are combined, they together form the leading cause of maternal death, both in the US and in Georgia. Next. And lastly, the US maternal mortality ratio continues to increase substantially. It's gone from 17.4 in 2018 to 32.9 in 2021. Some of the increase in 2021 was probably due to COVID deaths. So we're beginning to sort that out, and we've reviewed quite a few COVID deaths here in Georgia. I read an article from the Kaiser Family Foundation yesterday, and they said that they think the maternal mortality ratio for 2022 is probably going to drop since we will be over the COVID deaths, but we don't know if what that drop's going to be and if it will be a substantial drop. Next. All right, so let's focus on what's happening here in Georgia. This was our first maternal mortality report that the committee issued. Notice it came out in June of 2015, and it was from our case review in 2012. Took a little while to kind of get things going in this area, but we did publish this report, and it is available online for anyone who likes to review it on the Department of Public Health website. Next. Back one. Thank you. So in 2010, Amnesty International put out this publication called Deadly Delivery, the Maternal Health Care Crisis in the U.S. At that time, Georgia was noted to be the worst state for maternal mortality. Dead last, 50th, can't go down any further than that. So back in the and now this group called Wise Voter, which keeps a lot of statistics of various types, says that Georgia's 42nd in the state. We're not in the nation. We're not sure if that's correct or not. But back in the 1980s and early 1990s, I'm told, there was a maternal mortality review committee in Georgia. It used to meet in Macon. It was apparently a very robust committee for a while, but then finally fell by the wayside for lack of sustainability, lack of interest, and lack of funding. So when this publication from Amnesty International came out, I was sitting in my office at Grady, and Michael Lindsay, who was my co-MFM at Grady and my boss, came into my office and said, I need you to do something. I have been tasked with setting up a maternal mortality review committee again, and I want your help. So I kind of looked at him and thought, boy, I got so much other stuff to do. I started to say no, but it's hard to say no to your boss. And he kind of, any of you know Dr. Lindsay, he kind of has this look, he just looks at you and then you do what he wants you to do. So I am fortunate that when he asked me to do this, I felt that I needed to do it because it's been one of the most rewarding experiences in my career getting this committee up and running. Next. So the current Maternal Mortality Review Committee in Georgia is made up of about 45 members. I think we started with about 12 regulars, and it's grown over the course of the years. It's multidisciplinary in nature, and participants in the committee come from all areas of the state. We are supported by legislation, which is Senate Bill 273, which provides funding for the committee and also legal protection for members of the committee so that we don't have to testify on legal cases and so forth. We meet quarterly, 4 to 6 times per year to review about 20 to 25 maternal deaths per meeting. And we have trained abstractors that review each case and then develop a de-identified case summary for the committee to review. So when we review a case, we have like a 3 or 4 page summary about this patient's life and death. We know her age, we know her BMI, we know her parity, we know her education and occupation. We do not know her name. We do not know the county where she lived or died. We do not know the hospitals involved, and we do not know the providers involved, and the committee wants to keep it that way. So we examine all cases of maternal deaths, and we determine the cause of each death and if the death was pregnancy related or pregnancy associated. Again, this usually generates a lot of discussion among the committee members. We also identify medical and non-medical factors that potentially contributed to the maternal death. Next. We determine if the death could have been prevented and look at possible interventions that could have been taken to prevent the death. We make recommendations to key stakeholders to further reduce maternal mortality in Georgia. The stakeholders we typically report to or interact with a lot is the Department of Public Health and the Georgia legislature. And the Department of Public Health, let me say these 3 Ps, periodically publishes publicly available updates on the findings. So the maternal mortality reports come out about yearly now, I think is our goal, and they are available on the Department of Public Health website for anybody to review. DPH calculates the maternal mortality ratio each year when our reviews are complete. And then the committee also makes broader recommendations for reducing maternal mortality. And these typically go to patients, providers, family members, and the public. Next. Okay, so what are some of the findings from the state committee? Let's look at the causes of our pregnancy-related death by years. So from 2012 to 2015, we identified 28 maternal deaths, and we really had to figure out how to make sure we were reviewing all deaths, because when we went back and looked, we found that we had missed some deaths, and those had to be reviewed later. But from 2012 to 2015, we identified 28 deaths, with hemorrhage, hypertension, and cardiac issues being the leading causes of death. From 2018 to 2020, we identified 78 maternal deaths, with cardiomyopathy, hemorrhage, and mental health conditions being the three major causes. And then when you add the other cardiac conditions to cardiomyopathies, cardiac conditions in general were the leading cause of death. Next. Our pregnancy-associated deaths in Georgia by years, again, looking at the time period 2012 to 2015, motor vehicle accidents, homicides, and suicides were the three leading causes. 2018 to 2020, motor vehicle accidents, trauma, suicide, and then mental health condition were the leading causes of the pregnancy-associated deaths in Georgia. Next. So let's look at some of the findings that have come out recently from the MMRC. First of all, we noted that striking racial disparities exist in Georgia. The maternal mortality ratio among non-Hispanic Black women was 48.6 versus 22.7 for non-Hispanic whites in the period 2018 to 2020. Again, the etiology of these differences is not clear. In recent reviews over the past several years, almost all pregnancy-related deaths attributed to hemorrhage, mental health conditions, cardiac conditions, and preeclampsia and eclampsia were determined by the committee to have been preventable. Most patients experiencing a maternal death had Medicaid as their primary insurance, and most of the deaths occurred in the postpartum period in the first 42 days after delivery. We found in review of a lot of the cases that symptoms reported by patients who died were often overlooked as unimportant by the patient, by family members and providers, due to an overlap with symptoms that can be normal during the pregnancy and postpartum period. I'll always remember one patient in the postpartum period that had a cardiomyopathy. She went to different providers on about 3 or 4 different occasions in the first 3 or 4 weeks after her delivery, with the chief complaints of shortness of breath, chest pain, fatigue, her legs swelling. And she was told at every visit per her family members that providers just said, you know, you've just had a baby. Of course you're tired. Of course your feet are going to swell because you're up all the time. Sent home, and she died going back to her car in the parking lot after her last visit. So we really are trying to figure out how we can best educate our providers and patients to make sure that these symptoms are not overlooked. We found that comorbidities such as obesity, diabetes, hypertension, substance use, and mental health issues likely played a role in many of the maternal deaths. And again, we need a lot of education on concerning symptoms, along with encouragement to seek care when symptoms occur. We need to tell patients, advocate for yourself, go to the hospital, call your provider, whatever you need to do. If you are concerned about what's going on, your doctor needs to know. We also found that lack of access to care is very concerning here in Georgia. Georgia has 159 counties, and 82 of those counties have no OB providers or services at all, and another 15 have only one provider. 38 rural hospitals have, with labor and delivery units, have closed over the recent years, probably in the last 10 years or so. And this has resulted in large OB desert areas throughout the state, meaning it's hard for patients to access care. We also thought, as part of our findings, that discrimination and implicit and racial biases were also likely to have been key factors in some maternal deaths. Next. Okay, so let's look at some recommendations that the committee has made. First of all, we recommended that extension of postpartum Medicaid be done beyond the traditional 42 days. In 2021, the legislature did extend postpartum Medicaid for a full year postpartum. What I find with my patients at Grady is that they're not aware of this. So I tell every ultrasound patient I see, every clinic patient I see, that you have Medicaid for a full year after your baby's born. Make sure you're using that. We also recommended additional funding to support maternal morbidity and mortality reduction strategies statewide. So the legislature set aside $2 million for the implementation of the AIM bundles, which are the patient safety bundles, on management of hypertension and obstetric hemorrhage, and most of the funding went to support the initiation of these bundles in the rural setting. Use of family and informant interviews when a maternal death occurs. This sounds really straightforward, and if you can get a family member to talk to you about a patient who's died, it adds just such a richness to her life and to her death that you can't get by looking at an EMS report or a police report, coroner's report, her medical records, and so forth. So we really, over the past 3 years, have tried to fully implement this recommendation. Some states actually have legislation in place that prevent the Maternal Mortality Review Committee from talking to family members. Not sure why that's in place, but fortunately, Georgia, that does not happen in Georgia. And we talk to family members or other informants when we can. We recommended closer postpartum follow-up for women with high-risk conditions such as diabetes, hypertension, and obesity. And we've recommended blood pressure checks at 72 hours after discharge when patients have some form of preeclampsia. This is done typically by mobile health units. We have a very robust mobile health unit service at Grady, and all of our patients with preeclampsia have a visit within 3 days of discharge, and a report sent back to the provider about the woman's blood pressure and generally how she's doing. All of our patients with high blood pressure at Grady and in many hospitals and clinics across the state have provided blood pressure cuffs for their patients, and they've instructed them on how to use it, how to record your blood pressure, and then bring their logs into their clinic visits. And we're also using mobile health units to visit patients with high blood pressure who can't get back into the hospital. And a lot of this we are doing with telehealth visits. We like to see all of our postpartum patients at Grady, even our lowest patients, within 1 to 3 weeks of discharge. A lot of patients say they can't come back in because they've got a new baby or other issues going on at home. So we've utilized the telehealth services really robustly, and it's worked well for both providers and patients. Next. The obstetric care system, including providers, insurance companies, and hospitals, should actually be providing case management services for women during their pregnancy and up to 1 year postpartum. We should also, as I said earlier, be educating patients and families on warning signs and symptoms and that could indicate a life-threatening condition for the patient, or even maybe not life-threatening, but something that's concerning to the patient. And we are encouraging them to call their providers and to seek care. The committee recommended that providers should provide reproductive life planning, counseling, and interconception care when treating patients with chronic conditions of reproductive age. We want providers to encourage pregnancy spacing, and for moms who have diabetes and high blood pressure, we're encouraging them to come back in for a preconception visit so that we make sure their diabetes, their high blood pressure, whatever is well controlled so that they are ready to go through another pregnancy safely. And then we advocate for improved access to all areas of reproductive care for all women. This includes access to birth control and birth control counseling, and in situations where termination may be needed for a patient, usually for maternal health reason, then those options should be available also and reviewed with the patient. And then just kind of some general things. We've asked to expand and improve access to mental health services, and there are several initiatives in place statewide so that patients have access to mental health providers. We wanted improved communication and coordination of patient care during their pregnancies among providers and facilities. And for those hospitals like Grady and Emory that use Epic, this has helped tremendously because we can see what goes on at other Epic-based facilities too. Patients and families educated on warning signs, and also identifying and addressing barriers that limit access to quality maternal health care, both at the health system and societal level. For example, with my patients at Grady, I think the biggest barrier to them getting into care is transportation. So our high-risk nurses at every visit, new visit for a patient, instruct them on how to access the Medicaid transportation services. And for those patients that can do that, that's worked wonders for them, they say. Let me go back one, if you'll go back one, just quick. One slide. Thank you. We also have made recommendations, and this applies primarily to EMS, and we're working with our EMS providers to help develop some training modules for them. But transporting pregnant and postpartum patients to facilities with appropriate resources to take care of the patient is extremely important. We've seen in several situations where patients, say, with known accredited who were bleeding, were transported to a hospital that really was not set up to take care of their needs. But per EMS protocols, they often have to take them to the nearest facility. So we're trying to work out some mechanism to make sure patients get to the right facility for whatever issue they have going on. Next. And then just some kind of general public recommendations we've made. We wanted to encourage seatbelt use. We're still finding moms who are dying in motor vehicle accidents. Oftentimes there was no evidence of seatbelt use, enhanced gun safety campaigns. And then we really think it's important that maternal screening for intimate partner violence, substance abuse, and depression be done at every well woman, OB, and postpartum visit. And then development of public health campaigns from the Department of Public Health on the issues noted above, as well as on the need for good obstetric and postpartum care. We think these can be recommendations that will help here in Georgia. So in summary, our current maternal mortality statistics in Georgia need changing. A concerning number of deaths were determined by Georgia's MMRC to be preventable, especially true for our cardiac and coronary conditions and for our hemorrhage and mental health conditions. We noted that there are large racial disparities present in maternal deaths, and discrimination and implicit and racial bias were found to play a role in some maternal deaths. And then initiatives, fortunately, are underway to heighten awareness of these issues and to improve outcomes. Next. Some of these initiatives include the Department of Public Health and GAP QC's AIM initiative, the patient safety bundles, obstetric hemorrhage, hypertension have been rolled out. We are now attempting to roll out the cardiac conditions and obstetric care bundle because cardiac conditions are the leading cause of maternal death, both in Georgia and nationally. DPH has implemented the levels of care initiative, which is designed to make sure hospitals provide the levels of care for patients that they say they're able to provide, and that the patients get to the appropriate levels of care. And then here at Northeast Georgia, I'm so impressed with what you guys have done. The Hope for Georgia Moms program that you've got the large HRSA grant for. I'm delighted to be involved in helping with planning for some of these initiatives, and just a big pat on the back to you guys for this wonderful work. And then many of the university systems, Emory, Morehouse, Augusta, Mercer, are all implementing some type of maternal mortality or global health initiatives to help reduce severe maternal morbidity as well as maternal mortality. And of course, there are many groups in the community like Healthy Mothers, Healthy Babies, and the Black Mamas Matter Alliance that have quite a number of impressive initiatives in place and moving forward with improving care. So there's so many other individuals, groups, and organizations I could mention. But what I think it's going to take, it will take everyone working together in a very coordinated, patient-centered manner to achieve the maternal, fetal, and neonatal outcomes that our Georgia mothers, their babies, and their families deserve. And that's it. Thank you. There's my cell phone, just like everybody else does. Please call me if you have any questions. Thank you.
Thank you so much, Dr. Ellis. Are there any questions for Dr. Ellis from the audience you have to follow up?
One in the back.
Great.
Thank you, Dr. Ellis, for that.
Of course.
Is we have a lot of statistics now about maternal mortality. Where can we go to find more about morbidity and some of the things that we need to be doing to address that as well?
That's an excellent question, and thank you for that. I know Emory has developed a very robust program looking, and they're actually collecting a lot of data on this that I wasn't aware, that they are looking to collect data on severe maternal morbidity across the state, not the mortality, but the morbidity. And I think we are trying to get a database in place that will be available publicly in the near future. That, at least that's the plan at this point in time. So you're happy if you would email me, I'll keep you up to date on that. But I think the Department of Public Health, the GAP QC with the different initiatives, the Georgia Hospital Association, and other groups are also keeping data on severe maternal morbidity, since that is much more common than maternal mortality. And each of those groups have a data person that you can contact, or either just go to their websites and find out who their data people are, and they can tell you what type of information and how they can share that with you.
Thank you. So we are going to invite Heidi Ehrenreich and Savannah Sanders, and we're going to just do a few minutes of a panel discussion, and Dr. Ellis will just stay with us.
Okay.
So I will let Heidi and Savannah introduce themselves. Do you need a mic as well? I have one right here, or you want to? Real quick, and then we'll get a few questions.
All right, thank you. Yes, I'm the project director just since November of the Hope for Georgia Moms project. And before that, I was in the Office of Research, which I love. And I love that they have these events. So thank you, Holly and team, for organizing these. And my background is in public health. And so it was something that worked out really well, that they need someone to manage the grant and manage a lot of the activities. And I feel like that's something I want to do well, and hope that I can succeed with the vision that they had originally, and come up with some new ones as well, which we can probably talk about today.
Hello, my name is Savannah Sanders. I am a physician assistant here at GHI. I was specifically hired to be the women's heart coordinator for this maternal cardiac program that GHI has been working so hard to get up and running. I've been with GHI for about a year. I've been a part of creating this program since I've been hired, but really put a lot of focus on it starting around July, August. So just happy to be here and happy to be able to share where we are and where we're hoping to be.
Thank you both. And thank you so much, Dr. Ellis, for that wonderful presentation. Really, really informative. So I'll start with you, Dr. Ellis. You talked about implicit bias and how that was one of the things that was actually identified as possibly contributing to some of the maternal mortality. Would you share with us, as a physician, are there things that you're doing to help address that, or any thoughts on how other physicians can help address that?
That's a tough question, but it's one we are all dealing with. And I went back and looked up the definition of implicit bias, and the American Psychological Association, which I guess deals with a lot of terminology and all related to this area, defines it as a form of bias or prejudice that occurs unintentionally and automatically, that nevertheless influences and affects judgment, decisions, and behaviors. So I don't know if any of you, I wish I could see a show of hands, but we were required to do implicit training, bias training at Grady, which I thought, oh dear, what is this going to be? I was totally floored by what I found out about myself during that training. And they gave us a simple little task to start with, where they gave you patients' names, a pregnant patient, her BMI, and a medical condition or two. And then the task was, okay, this is a patient you've never met. Here's the basic information. Tell us about this patient. What do you think before you walk in the room about this patient? And I was quite surprised at my own biases that came out. So we at Grady have been doing a lot of training with our physicians to try to recognize those biases and not let them get in the way of patient and provider interactions. But it can be hard to do, but we have to work at it, and we have to make sure we're not letting those biases influence the way we interact with our patients and the way we take care of our patients. But it's hard. It's a daily effort to remember those things.
Great. Thank you so much. Heidi, tell us a little bit about Hope for Georgia Moms.
Okay. Well, basically, it's a 5-year program to reduce maternal mortality in Georgia. And how are we going to do that? Well, the vision of the people who created this grant, which was written by Bridget and Mary Lou Wilson, who said, look, we know cardiac conditions, what we hear today is a leading cause of death. Let's do something about it. So they made this incredible proposal to HRSA, Health Resources and Service Administration, who said, look, implement this program. And we think, by facing maternal cardiac conditions as among pregnant postpartum women, that if we identify those signs and symptoms and have a screening, that would be really something that would make a difference in maternal mortality. And so that's one big part of Hope for Georgia Moms. Another part really is data, right? We're talking about where do you get SMM data, the morbidity data. It's still challenging. We need to help work on getting better data. We want better mortality data that's submitted when we're in a timely manner so that the committee can review it in a more up-to-date fashion. Also, the morbidity data isn't always submitted. It's voluntary by health systems. And so we thought, okay, well, we'll work on a registry here at Northeast Georgia Health System with this morbidity data. And wouldn't it be great if other health systems also could create some registry of their own and we could all submit it? So this is sort of a vision, a dream that we have and part of Hope for Georgia Moms. And then the third part of Hope for Georgia Moms is really the centerpiece of why I think it can work, and that's the task force. And the task force is made up of members like Dr. Ellis, other professionals who've been working for years and years in this field, have been working hard in understanding how to improve it. So we have clinicians, we have medical directors, for example, of payer systems. It'll be from Blue Cross Blue Shield, of United Healthcare, of Medicaid. We have regional perinatal center directors, besides Dr. Ellis, also from Augusta University. We have research institutes like the Rural Health Center for Rural Center for Health Disparities out of Macon. We have a lot of community-based organizations doing great work. So we heard about Healthy Mothers, Healthy Babies, Black Mamas Matter. They do a lot of work in policy. So we're really approaching it from all different perspectives. And the vision here is to say, okay, we bring these people from, elevate what they're doing and sort of move on from there. So organically kind of create something that can move the needle, basically. And so we want to move the needle. And just to wrap it up, Hope for Georgia Moms, yes, it's about reducing mortality, but really we want to make it about people wanting to have babies, not worrying about they're dying or their babies dying. So we want to have joy in that. And we call it HOPE, and that's healthy outcomes and positive, equitable experiences for Georgia moms. And we hope that that is the vision that we can sort of, further through our time in this grant. So.
Thank you so much. Savannah, I have a question for you now. So we've heard a lot about mortality across the state, and we've heard a little bit about HOPE, who we hope over the next 5 years, no pun intended, that we can impact that in some way. So let's talk about some of the things happening at Northeast Georgia specifically. Tell us a little bit about the maternal cardiac program here at Northeast Georgia.
Absolutely. So here at the Maternal Cardiac Program, we are currently screening moms for cardiovascular conditions day one post-delivery on mother and baby unit. Things that we're looking for on this screening are they currently having signs and symptoms of cardiac conditions? Are their vital signs elevated? Do they have risk factors? And then, of course, do they have any sort of physical exam finding that might make us say, this is not normal? All of that is gathered together. And if a patient is deemed at risk, then they are sent to us either by an inpatient consult or by an ambulatory referral. And through that point, it is our goal to monitor those patients for a full year postpartum. Just as Dr. Ellis has said, that it used to be that we only want to see them for 6 weeks. Once you get through that 6 weeks, you're in the clear. And we now know that that is not the case, that we need to monitor our mothers and make our mothers aware of, the risk that they're at for a full year postpartum. So until they celebrate their baby's first birthday, if they start having new signs or symptoms, they need to make us aware, the OB aware. Someone needs to be communicating, advocate for yourself. Again, with cardiac conditions, oftentimes can sound like pregnancy symptoms. Oh, you're short of breath. Oh, you have swelling in your feet. Oh, you're tired. Well, when you're pregnant, oftentimes that gets told that it's normal. But if you have someone who has a history of cardiac conditions, if they came to me and said, I have shortness of breath, my legs are swelling and I'm tired all the time, I go, well, you might be having, an exacerbation of some sort of cardiac condition. We should look into this. So we can't rule out cardiac conditions for women who have these symptoms. And putting the education out there is something that we're really trying to do with this Women's Heart Center as well. We would like to be able to make telehealth an opportunity and remote patient monitoring an opportunity where our women who have preeclampsia or postpartum preeclampsia, that they can monitor their blood pressure at home. It's not standard for most young women to have a blood pressure cuff at home. So what can we do to help them have the resources to monitor their blood pressure? And then of course, telehealth. They're young moms. They need to work. They want to care for their children. They don't want to come in and see me and say, well, I don't have time. I don't have somebody to keep my kid. Well, I have 3 kids. I can't bring all 3 kids to my doctor's office. There becomes lots of barriers to care. So we're hoping within this maternal cardiac program that we can help open up some telehealth opportunities to at least get these moms seen and taken care of as well.
Thank you so much. And this question is for any of you or all of you. Tell me what you think would be one first step that we could take that could help impact maternal mortality. We'll start with you, Dr. Ellis.
Well, I think, I'm delighted to see that Medicaid has been extended for a year. It's going to take a while for us to see the impact of that. But I really think a lot of patient education on that issue, encouraging them to utilize that, to come in when you have symptoms, to schedule visits. If you're not feeling good, please come to the hospital, call Medicaid. I think teaching patients to advocate for themselves and have them make us listen to them when they are advocating for themselves, which they're going to be able to do a little bit more effectively, I think, with Medicaid, with their extended Medicaid. But I think we just need to learn to listen to our patients and encourage our patients to make us listen to them.
Thank you.
I would agree completely, Dr. Ellis. I think we need to listen to our patients, but also I feel like it's important that we educate our patients as well. Being a mom and being a young female, oftentimes I go, oh, I'll sleep it off, or, oh, it's just been a bad day. I'll think about it tomorrow. Oh, I had 2 high blood pressure readings. I probably just drank too much caffeine. We're always looking for that excuse of why there's something that's not wrong. And sometimes we do have to accept, okay, I do need to seek help for myself. One thing that I tell all of my patients is you can't take care of your kids. You can't take care of your family. You can't take care of who you need to take care of if you don't take care of yourself first. So when you recognize those symptoms and you recognize that there's something going on, reach out so that you can care for yourself, so that you can be there to care for those other family members.
Perfect. Thank you.
I think I would add to what you both are saying that I really see it as a systems approach that we would really need. You might have the best education or the best approaches in place, but if we don't have sort of the systems to make it sort of possible, there can be just a lot of barriers. And what I mean by systems can mean a lot of things, I realize, but just one that comes to mind would be sort of policy, kind of at the same time dovetailing into what the proposals are. Another would be just kind of on a if we want change, like in the hospital system, we know that a lot of things, if they're automated, right, through Epic or something like that, it's going to happen more readily, right? Even if people want and understand that it's the right thing to do, if it doesn't work in the workflow, then there's going to be barriers. So if I could see one thing, is taking something that is pretty well developed, whether it's education or advocacy campaigns, and being able to kind of see how they can be implemented kind of in their systems better. And maybe that kind of goes back to what Dr. Taylor's talk. What are those systems defining it? I don't have those answers either, but I like that approach.
Great, thank you. I think another thing that has really stood out for this program and for the work that we've done so far is collaboration. And I love that we started this at a time that OB was coming to the table, because our state perinatal quality collaborative that you've heard today decided to focus on cardiac conditions. And at the same time, when we got to the table with GHI and said, we really need to partner with you, they were working on the Women's Heart Center, and Savannah came on board. So really has been a great collaboration. But I have a question, and anyone can answer this as well. Other than OB and cardiology, what partner would you want most at the table to be successful in this whole cardiac conditions rollout?
For me, there's not just one.
The biggest one.
So I can't pick one, because exactly what you're saying is that vision here is to have this multidisciplinary team. The women that we're seeing, they are not simple. They're not straightforward. You have the fetus that you're caring for, or the baby that they've just delivered that they're caring for. So you have to think about that dynamic. You have to think about, what about whenever they get home? Are they going to have the support that they need? What about medications? A lot of the medications that are for cardiac conditions we can't use if you're pregnant or if you're breastfeeding. What does that dynamic look like? So having a multidisciplinary team. We have recently hired a pharmacist to be able to help with some of these pharmaceutical concerns, who can be helpful in managing these patients with diabetes during their pregnancy, adjusting their insulin, giving them education, same guidance when it comes to medications for what can we give you whenever you're breastfeeding, what can we give you while you're pregnant, give them education on, hey, we need to give it a chance to work, or hey, we've given it a chance to work, we need to talk about other options. And having that resource not only for the patient to utilize, but also for providers as well. Sometimes when we hear the word pregnancy, everybody kind of cringes, like, I don't want to deal with that. Also, there's a new social worker that we're hoping to get involved as well, who can help get them the education that they need as far as resources, outpatient, and getting them connected. So a dietitian who can help some of these women who maybe they're at risk because they have high blood pressure, they have obesity. Maybe if we could help get some of that weight loss down, would that also help with some of these other things that are going on? Having a dietitian there to help support them, a dietitian to help them during their breastfeeding process. Hey, what do you need to eat to help with your production, or what is going to help throughout this process? So having everybody at the table is super important to me. So that's why I can't just pick one, Bridget.
It's okay. Dr. Ellis?
Yeah, and those are all wonderful suggestions. We have an OB pharmacist at Grady who is just phenomenal. I learn more from her every day that, I didn't think I didn't know, but she's great. But also, I think across the state, we're looking to educate our family medicine and our ED providers about issues related to especially cardiac conditions, because in many areas of the state where there's no OB provider or not even a midwife to go to, our patients are going to EDs and they're going to family medicine practices. And those providers are, of course, doing everything they can to help the patient. But pregnancy is a different ball of wax. As you say, everybody is scared of a pregnant woman. So we need a lot of education, I think, for all the providers out there who are going to be helping us take care of our pregnant patients and postpartum patients too.
Thank you. And I think our time is getting very close. Are there any questions in the audience? I'd love to. Yes, Robin? I can repeat it.
Online, they might not be able to.
I can
hear.
repeat it if you want to yell it out. Oh, here comes the mic. Holly to the rescue.
Thanks. Savannah, can you walk me through if you come see one of my postpartum patients who is at risk or symptomatic, what does that look like for that visit that you see her face to face while she's on mom baby, and what it looks like for her the next few weeks after she's discharged?
Absolutely. So a lot of it will depend on the reason that they screened positive. But just for the most part, if they screen positive, we're going to get an EKG and an NT-proBNP on those patients. An NT-proBNP is something that can kind of help us let us know if they are at risk or have any signs of heart failure, which we know cardiomyopathy is a huge component, as well as getting this EKG to see if there's any acute abnormalities with those EKGs. And ultimately myself or a fellow MD cardiologist who is rounding that day will likely come and see that patient, ask her, do you have any sort of family history? Have you experienced this in prior pregnancies? How is your blood pressure? Those sort of things. So we try to take a look at the whole picture of how the patient looks physically. Is she symptomatic? Is she, how does she feel? And then also currently looking at vitals, look at lab results, things like that. And if there's anything that needs to be treated, such as blood pressure, things like that, we will, of course, titrate any medications necessary. But ideally, after we see them in the hospital, answer any questions, provide them with the education of, hey, because you screened positive, we do want to follow you for a full year. We want to follow them closely initially. So ideally, most OBs are either following at week 1 and week 6 or only at week 6. So I want to try to fill in that gap and go for more of that 3 to 4 or 2 to 3 so that we can kind of find that happy medium for the patient, so that they're not missing care within that 6-week mark from the OBs. And then after that, depending on patient needs, either 3 to 4 months after that, every 3 to 4 months until we hit that year mark. Of course, if patient needs to be seen sooner or more often, we can make that happen. But I do want to have them seen frequently throughout, which is why telehealth to me is so important, because some of these women, they don't have quote unquote a condition currently. They're just at risk, and there's nothing that says that they will develop anything. It may just mean you might have diabetes when, later in life, earlier than some of your other people your age, or you may develop hypertension later. But we are trying to catch those current conditions. So we want to do some telehealth options for those individuals who maybe they are only at risk and nothing currently acute going on. So I don't want somebody having to come in every 3 months to say, by the way, you're still good. By the way, you're still good. We can do that virtually. And then of course have that option for patients to come in who say, hey, remember last visit, you told me if I started having shortness of breath that I needed to come see you. Well, here I am. I just want that door to always be open for them to say, I'm having shortness of breath. I don't know who to go to. My OB, I'm not pregnant. This isn't an OB concern. And then just as Dr. Ellis was saying, sometimes our family medicine doctors, they're not asking, are you postpartum? That's a common question that's not being asked. So if they're 6 months postpartum presenting with shortness of breath and leg swelling, that consideration of a cardiac concern may not be considered. So I hope that answered your question.
I think we have time for one more. Well, we don't really have time for one more, but we're going to take one more. How about
Hi,
that?
this is Cheryl Biddle. Dr. Ellis, thank you so much. It was very inspiring, and it makes me feel very privileged that I had good, OB and postpartum experiences, but it was very very eye-opening. You know, we have a book club coming up. It starts November 1st. I know I'm facilitating part of that, and it's related to the book is How to Be a Patient by Sana Goldberg. She's an RN, so she looks at it from both a healthcare provider perspective as well as a patient and family member. And I'm telling you, it's really very helpful. And I think that probably all healthcare providers should probably take a look at that so that they know what patients do experience and how to modify their presentation to them when they're visiting them.
Thank you
Should
for
I-
that. And let me say one thing right quick, back on implicit bias. If there are great training programs that can be utilized to help providers. I did one with the March of Dimes and then one with A1, which is the Association of Women Health Obstetric and Neonatal Nurses. They have a program called Speak Up, and it's a great program for training providers on implicit bias. I really appreciate all the discussion that's gone on today. Thank you so much for the opportunity to participate.
Everyone, thank you.